Hi, just before you watch this recording, we'd like to make you aware of an invitation to participate in some research evaluating the impact of our campaign, which has been approved by an ethics board at Teesside University. The research in this area is really important, so we'd be very grateful if you could take part. All you have to do is complete a short survey before watching the event. You can find the link to that evaluation below this video. Teesside University will then be in touch directly in the future to tell you about future participation. Thank you very much.
Hello and welcome to our latest Flippin' Pain event, this time with a focus on osteoarthritis, and kicking off with a presentation from the brilliant Associate Professor Tasha Stanton. My name is Felicity Thou and I'm a physiotherapist and member of the Flippin' Pain team, and I'll be hosting today's event, including the question and answer session with our panel at the end. I'll introduce our panel a little later, but they are from a whole host of backgrounds, from an orthopaedic surgeon to a GP to people who live with pain and arthritis themselves. As ever, please ask your questions via the Q&A function that you'll see on the screen, and be aware that we can't offer any personal medical advice today. And so, to the event. I have great pleasure to introduce Associate Professor Tasha Stanton of the University of South Australia, from where she is joining us across time zones today. Tasha is a pain neuroscientist with a special interest in osteoarthritis, and I'm delighted to hand over to her for this presentation. Hi, Tasha. I've got your slides, I've just got you on mute.
Here we go. Hello there, everyone. Hello, technology. Thank you so much for joining today. I'm incredibly excited to be part of this event. And as you can see, I'm today talking about flipping arthritis. And the title of my talk is really ensuring people who get it. And what I really mean by that is people who have and experience osteoarthritis, ensuring that they get the best, most up-to-date information that impacts their condition, but also their treatment. So today, I have seen that there's quite a broad audience joining us, and that's fantastic. We have people all the way from those experiencing arthritic pain, those that might have pain from another type of condition, as well as people who might be healthcare professionals. So today, I'm going to focus more of my message towards people who have osteoarthritic pain. But don't be alarmed, it still applies to many of the other listeners here. And I'm going to focus some of the information that I'm providing, particularly on knee osteoarthritis, because this is really my area of specialty. But again, be assured that many of these things apply. So arthritis is a really interesting thing, because it's one of those conditions that, we really thought we had everything sorted. We thought we knew everything about arthritis. We know what it is. We can easily diagnose this. We just have to look at an X-ray or an MRI. And not only that is, we know how to treat it. So we have this thought that, what we can do is stave off the effects of osteoarthritis by, generally staying active, keeping weight off, keeping the legs strong. And, that'll be all good. But eventually, unfortunately, osteoarthritis is a degenerative disease, so it's going to progress, and that will likely need or result in a total joint replacement. And the idea is that we then cut out that damaged joint, replace it with a shiny new one, and everything's good. However, if that were the case, and if all we had to do was, cut out that degenerative knee joint and replace it with something new, then total joint replacements really would be the cure. And well, we do see that they are helpful for many people. Actually, joint replacement outcomes are not as good as we might think, particularly when we ask patients, not necessarily ask surgeons. So when we ask patients how they've gone with a joint replacement, what we find is that actually about 10 to 34% of them don't have a great long-term pain outcome. And up to 15% of them actually report that they still have moderate to severe pain up to 5 years post total knee replacement. And this is intriguing because this isn't pain that's occurring because of infection or because there's a problem with a prosthesis. This seems to be similar pain as to what they've had before that might be worse. And so while some people do get benefits, the fact that for some people there's not very good outcomes really speaks to this idea that osteoarthritic pain might be more complex than we think. So it's relevant then to have a little bit of a look at what people with osteoarthritis have been told and what they think about their osteoarthritic pain. And so if we look into the literature, there's been some beautiful qualitative work done where it's been asking people with osteoarthritis. And what's come across quite strongly is this idea that for many of them, they have very strong beliefs that what is going on is wear and tear. So there's been, damage to the joint, and the more that they do, the more that it ultimately is worn or damaged. And with an idea that the pain that's being experienced is largely because it's bone on bone. A thought that the cartilage, that tough, cover of substance that covers the bones of your joints, that's been lost. And together, these things create a vulnerable joint. And because there's this, wear and tear and degenerative joint, there's these beliefs that actually, of course, it's going to degenerate or deteriorate over time. It's probably going to get worse. And this, of course, then has sequelae or consequences to what we think might be the options. So, for example, when people often, if they strongly think, I've got bone-on-bone osteoarthritis, I really don't see how anything else but surgery would help, because ultimately I need to replace that worn out cartilage. I need to have a new joint. But then the problem with this, of course, is that if we look to the very best level evidence that we have, actually activity and exercise are some of the most highly recommended things to reduce pain and increase function in people who have painful knee osteoarthritis, even when it's very severe. And yet, oftentimes, people, when we ask them, will think that, I don't actually think that loading is good for my knee. I think it might do more damage. And that's not unreasonable, is it? So let's look a little bit further at some of the things that people have said in terms of exercise. So these are some quotes from different people who have painful knee osteoarthritis. And this is someone who said, it seems common sense that if you've had deterioration in the joint, like which arthritis is, then, the more you do, the more it's going to be worn, I wouldn't have thought it's something that would get better with practice, with exercise. Or if it's your bones that's grating together, causing that much pain because there's wear and tear, then, how's the muscles above and below really going to help? And these are incredibly relevant questions. Because I would argue that when we tell you to move, advice to move makes absolutely no sense unless we first understand that osteoarthritis is actually not merely a wear and tear disease of the joint. Because ultimately, that's what the science is suggesting. So when we look back at some of these things that people with osteoarthritis have been told and that they think and believe about their own osteoarthritis, what we actually see is many of these things are myths and misperceptions. So what I'd like to do today is I would like to explore with you some of these different myths. And I want to bring to you some of the new science that we know in this area that really does suggest that these are indeed myths. So the first one I want to tackle is this idea of wear and tear. And this is a really common one. The idea is that, the more that we wear something, the more that it's going to tear or be damaged. And I think one of the most common things that people are told about this is that, if you lose a little bit of weight, that'll be really helpful. It'll reduce loading through the joint. It'll make it so that you're not having as much weight going through that joint, and that will help reduce wear and tear. But let's explore that. So what we see when we look at the science in this area is that weight does matter, but it's not how you might think. So if we look at someone that has a higher body weight, but this is due to higher levels of body fat, that is indeed associated with increased knee cartilage loss over time. So in other words, a progression of osteoarthritis. But if you have someone who has a higher weight, but it's due to higher levels of lean mass or muscle mass, then actually that's associated with either a reduction in knee cartilage loss or a maintenance of cartilage. So not a progression in osteoarthritis. So what this actually suggests is that it's not extra body weight that's contributing to osteoarthritis progression, it's actually having extra body fat. And what's intriguing about this is it's supported by findings that show that levels of obesity actually can predict progression of hand osteoarthritis, which of course is a non-weight-bearing joint. There's going to be no change in the load unless you're a gymnast, I suppose, when you have higher levels of weight. So it kind of suggests that in this case, wear isn't really equaling tear necessarily, but instead, actually obesity, what the science is telling us is that obesity contributes to inflammatory responses in osteoarthritis. And I'm going to speak a little bit about this further, but when I'm speaking about inflammatory responses, I'm really talking about almost like when you get the flu and you kind of feel crappy, but also everything hurts more. You're more sensitive. That's what I'm sort of referring to here. But another, I guess, aspect that we have of this is this idea that when a joint, when it's undergoing maybe this myth of wear and tear, one of the problems is that it's bone on bone. And so if you have problems with your cartilage, then doing more activity actually might further damage that cartilage. And again, that's largely, well, potentially a myth based on the relevant science. So if we look at the newest evidence in cartilage, well, we actually know that cartilage loves loading. And importantly, cartilage can adapt. If we look at astronauts that go into space, so there is no gravity, there's the complete absence of loading any weight through that joint, what we see is that their cartilage is thinner when they come back. If we look at marathon runners, on the other hand, they're the ultimate wear and tearers, so to speak, aren't they? They're putting so many miles on their limbs. And yet for many marathon runners, they don't have reduced cartilage, they have actually increased cartilage thickness. And so it suggests that actually, first of all, cartilage can adapt. And if we look at some of that, the physiology behind this, what we do know is actually cartilage doesn't have a blood supply. So it gets its nutrients through compression and load. So it's really important that we load cartilage. What's more is we have these specialized cells within the cartilage itself, and they help make different substances that help keep the cartilage strong. And they're called chondrocytes, and chondrocytes, these specialized cells, they love loading. When they're loaded, parts of them called daughter cells will actually go forth into the joint and find and go to different areas where there might be cartilage damage. And this process is slow, but it happens. So it might be more accurate to say that cartilage wears and repairs. Now, for the astute of you in there, the clever folks in the audience, you might be thinking, well, if cartilage loves loading so much, then why does it still hurt when I move? If it's hurting when I move, doesn't that necessarily mean I might not be doing something very good for my joint? Is it possible that when it hurts when I move, I'm actually damaging my joint further? And it's interesting when we look into the literature, because there's potentially a reason for feeling pain or more pain when we're moving. And that's because when we look at people with osteoarthritis in various lab studies, we see evidence that there are changes to the nervous system that mean the nervous system itself is overprotective. So let me give you an example of this. one way that we look at overprotectiveness of the system is we use a very simple test that's called a pressure pain threshold. So pressing on the skin and seeing the force at which you first feel pain. Now, if we take people who have painful knee osteoarthritis and we do these pressure pain thresholds throughout their body, what we see is they're always more sensitive, regardless of where we test it, whether we test it at the painful knee, whether we test it at the non-painful thumb, the trapezius muscle that isn't painful. They are still more sensitive than people who don't have osteoarthritis. They're the red bars there. It takes less force to elicit pain. So this is indicative potentially that the system itself is more sensitive. But why might that be? To answer that question, we need to take a little bit of a step back and just review how we think the experience of pain itself occurs. So here we have someone who's stepping on a thumbtack. They've injured their body. When that happens, we know that there are specialized cells within that area that are called nociceptors, or we also like to call them danger detectors, and they will activate. When they activate, then they send a message up the nerve, and that nerve goes to the spinal cord. And we have these same nociceptors, whether it's stepping on a thumbtack, we have the same things in our joints. So in our, for example, our osteoarthritic knee. So when that message then goes up to the spinal cord, it talks or communicates to another neuron that's within an area of the spinal cord called the dorsal horn. Then another nerve basically goes up the spinal cord, talks to a few more different areas, and then ultimately goes up to the brain. Now, in the past, what we thought was happening was that when something like this occurs, we get a message of pain that's going up to the brain, and the brain basically just reads out how big that signal is. But that's not what it actually is, not based on our contemporary understanding of pain. What we understand is that it's not a message of pain that's being sent up to the brain. What it actually is it's a message of danger or threat. And the brain's job is then to consider that message of danger or threat that's coming from the periphery, from this area, but also all the other different relevant information for that person in their environment, all the other things that might provide evidence about whether they need to be protected. Because ultimately, that's the job, is determining, do I need to be protected? And if you do, then an output of pain is occurring. And what it means is that what's coming up can be changed and influenced by many different things. Now, what I'd like to do first is I just want to focus on what happens with the danger message in people who have painful osteoarthritis and why that might matter to how much pain you feel when you're moving. So the danger message itself, it can be influenced by inflammation. And what we're actually finding from the recent literature is that osteoarthritis involves having increased levels of body-wide inflammation. So throughout the body, but also in the joint as well. And we think that some of this, as I mentioned before, can come with when we hold higher levels of fat in the body. What it can actually do for those science nerds out there is it can cause the fat can release something called adipokines. And adipokines, they can mediate or help along the inflammatory response. So that can happen. We know that we have higher levels of this body-wide inflammation as we get older. But we also are starting to understand that there are links to our gut. So we have within our gut a microbiome, so it involves a bunch of different things, but it can communicate with our circulation. So it can, through the microbiome and through changes that can occur in this, it can also influence the level of inflammation that's there. So we have in people with osteoarthritis numerous different contributors to increase inflammation. And when we have inflammation present, there's some influences on what happens. So let's say this is your knee joint that has osteoarthritis, and you're walking. There will likely be a certain level of activity from those danger detectors, sending up that danger message to the brain. But when we have inflammation, what it does is it makes those danger detectors more sensitive. And it also means that those danger detectors bring in extra friends. The silent danger detectors that normally might not be involved are now activating. And so what we get is we actually get an increase in the danger message that then is being sent up that nerve. So despite the fact that the knee is exactly the same, you can have an increase in that danger message based on inflammation. Now, when we get to the spinal cord, we see a really similar thing. First of all, sustained input to it can make it more sensitive. And when inflammation is present, again, it can make those neurons in the spinal cord more sensitive. And it can have them bring in extra friends. So we know that when things are quite sensitive, even now touch information coming just from your skin can now activate that danger pathway. So again, we get a danger message that can potentially be increased, despite the fact that there's been no change at all in the knee joint. And then that is sent up to the brain. And again, you might guess it, with inflammation, that can also change the size of that signal there. So just to recap, we've started from something. This might be the danger message that's coming from your joint, that then when all of these different changes occur due to inflammation, suddenly it becomes this, with the possibility of also being increased when it's up in the brain based on those other factors that I talked about previously, but I'm going to come back to and explain in more detail. But in general, we see that the amount of danger message going up to the brain can be very different. And actually, honestly, this sounds like it's a bad thing, but in many conditions it's not. When you sprain an ankle, this is exactly what we want to happen because it makes us hurt more and it makes us stop doing what we're doing. But in osteoarthritis, it can mean that this pathway is sensitized. And we know that actually we have inbuilt systems within our pain system to help regulate this sensitivity. And we like to call them the brakes and the accelerators of the system. So it can change, basically the brain can send a message down to the spinal cord and change how sensitive things are. Now, a relevant one here is that we have a natural brake, putting the foot on the brake. And what we find though is that in people with osteoarthritis, the brakes are impaired. So on average, they have a 20% reduction in their ability to inhibit sensitivity or reduce down the sensitivity. And in some people, it might be reduced to half. And what's more is the accelerator is working too well. So on average, people are getting an increase in the sensitivity based on these different systems. So unfortunately, the normal things that are regulating how sensitive that system is don't seem to be working quite right. So together, these changes in the neuroimmune system in painful osteoarthritis, they're a little bit like road rage, but when you're hungry. So think about getting cut off when you're driving. You're like kind of mad. You're like, oh, that was really dangerous. Like, oh, very annoyed at that. However, think about being starving hungry and then being cut off while you're driving. What's the reaction? First of all, it's enormous, isn't it? It's like, oh, what are you doing? That was so dangerous. I can't believe that person just cut me off. But then it's not even enough. You get to the next light, and that idiot at the front, he didn't even go, and all he had to do was watch that turn light. Then you see a person standing on the side of the road like an idiot. You're having this hugely large reaction to something that wasn't very big, and you have no food in the car to stave off that enhanced response. And so this almost enhanced reaction to potentially a relatively minor road event is a little bit similar in the sense that oftentimes the amount of pain that we experience doesn't necessarily reflect the amount of tissue damage present because of all these different changes that are occurring in the system. And why does this matter? Well, let's look at it in the context of activity. So this mountain is the amount of activity that you can do. And in a person who's healthy, who has no pain at all, we will all still have a certain tissue capacity where if we do way too much activity, we will injure ourselves. But the important thing from this is that we all have a safety buffer. We have a protect by pain line that occurs before we injure ourselves, because that's important. That's the point of pain. It's the alarm system to help us not injure ourselves. However, when we look at someone who has osteoarthritis, there is evidence that the tissue capacity is often reduced. There are changes going on. However, based on all those changes that I've described to you about how the system is more sensitive, what we get is an enlarged safety buffer. And this safety buffer means that now even very low levels of activity are starting to be painful. So our system itself becomes overprotective. But the key bit of this is that even though you might be feeling pain when you're doing some activity, you're pushing just into the safety buffer. You're nowhere near that tissue capacity. And that's critical because it means when we're moving, you can be sore, but rest assured, you're safe. You're nowhere near damaging that joint further as long as we're not doing anything silly. And a critical aspect of all of this is that this overprotection, this big safety buffer, can also be maintained by things like beliefs, like fears, like anxiety, like how much sleep we got the night before, which also means that that safety buffer can be changeable. So that was a lot of information. What I want us all to do is just take a little stretch, reach for the stars, shrug your shoulders, have some breaths, shake the shoulders loose. It's always hard listening online. I know sometimes I get a little bit bored when I'm listening online, so let's keep us activated. But what I've told us here is that the system itself can become sensitive, and it can mean that we have this overprotective system that makes kind of more sense why things like might hurt when we're moving, even though moving in load is actually really good for cartilage. So I focused mainly for the first bit on this danger message. What I want to talk about now is I want to talk about how all of these other features like your knowledge or your feelings, fears and anxieties, things like that can contribute and play an important role in the pain that you might feel. So based on the available evidence that we have, we know that we have a dynamic pain system that adapts and it updates based on the available information for that person in the environment and in that society you're in. And ultimately, what it's doing is it's comparing and considering the credible evidence there is that you're in danger and balancing that with the credible evidence of safety. And when danger outweighs safety, ultimately things hurt more. When safety outweighs danger, things can hurt less. So importantly, what that then means is that anything that suggests that you need protecting can increase pain. Anything that suggests you don't need protecting can reduce pain. And the reason that's important is because it gives you the opportunity to consider your unique balance. And we call this your dim sims, or your danger in me's, your safety in me. And what can be helpful here is looking at contributing factors that may be providing credible evidence of either danger or safety. So for example, one thing that may well provide credible evidence of danger is looking at my knee scan. Maybe there's some scary words that I'm not really quite sure what they mean, but also it sounds bad. That might provide credible evidence of danger, one point in that danger side. In contrast, a safety in me might be, feeling strength in my thigh muscles, knowing that my leg feels strong. A danger in me can also involve the things that you do. So potentially doing knee exercises can be a danger in me. If you're really not sure if those knee exercises are good for you and you're a bit concerned that your knee hurts while you're doing them, that could provide credible evidence of danger. In contrast, actually the exact same thing for some people might provide credible evidence of safety. If we know that actually these knee exercises, they're really good for my joint. And even though I'm a bit sore when I'm doing them, I know what I'm doing is I'm making myself stronger and I'm loading the joint to help keep my cartilage healthy. It can also be the things that we might say. So things like wear and tear and saying it all the time can provide these reinforcements of danger. In contrast, things like wear and repair might provide evidence of safety. It might also be things that we believe. Really strongly believing that surgery is inevitable no matter what I do can contribute to this sense or this feeling of danger. Whereas an idea or a belief that, actually there are many ways to improve my osteoarthritis, that can provide safety. Places you go, doctor's office, that can feel dangerous sometimes. And compare that to, dancing class with your best friend. People around you can provide dangerous safety signals. So an out-of-date health professional or a nosy neighbor might be danger, or an up-to-date health professional and a supportive family might be a really important safety cue. And last but not least, the general sense that you have, how you're feeling about your trajectory and where you're going. Do you feel, depressed and anxious? I don't think anything's going to change. It's just going to get worse. Or happy and optimistic. I think there's actually a lot of things that I can do for my osteoarthritis. And there's this sense of hope. And ultimately, your unique balance of these different things can determine whether or not something hurts more or hurts less. So this might seem odd, and this might be really new information that you've not heard before. But part of this, I think why it can be hard to grasp is that we're not aware that these various things are necessarily changing the sensitivity of our system. And actually, there are a lot of different experiences that that are shaped by things that we are not even aware of. And I want to give you an example of this, just to hit this home, that actually what we can experience can be influenced by things that we're not even aware of, just like these safety and danger things. This is a really famous illusion called the rotating mask. You'll see it right now rotating towards your right, and now it's just about to start to rotate to your left. And again, it's going to switch direction, and it's going to rotate to your right. Now, why this is a very famous illusion is that mask is actually never changing direction. It is always rotating in the same direction. But here's the thing. Your brain has learned that faces, they curve outwards. And so your brain would rather change the direction that is rotating, make it look different to you, than for you to see a face curving inwards because it's not correct. Isn't that weird? You're not aware that this is happening. And annoyingly, despite the fact that I've told you that, you can't unsee this illusion. But the good thing about SIMS and DIMS, safety in me's, danger in me's, is that when we change those, we are able to change how much pain we feel. And one of the key things that adds to this is, and particularly that underpins many of how we perceive the things, whether they're safe or dangerous, really relies on this fact that your knowledge and your beliefs about osteoarthritis really matter. And I want to give you an experiment study to back up why this is so important. So if we take healthy volunteers and we take them into the lab and we control every single thing that we can, what we found is that your knowledge and beliefs about your own body will influence how much pain you feel. So in this experiment, people were being zapped with a laser, and a fake skin assessment was done. They were either told that this part of the skin, totally safe, laser resistant, you're totally fine to get a laser here. this area, I'm not quite sure if it's safe. It should be fine if we zap you with a laser, but we'll just be cautious and watch. But completely safe. It's completely fake. It's completely safe to get zapped in any of these areas, but the people don't know that. Then they're zapped with a laser. And what they found was that when you zap areas where people are not sure that it's safe, it hurts more. Despite the fact that it's an absolutely identical laser zap, it hurts more when you're not sure that something's safe. And this becomes relevant because in this case, we have, this health or this researcher that seems trustworthy vaguely, telling you that this isn't safe. What do you think happens when we have trusted health professionals that might have given us messages that some of our things that we do might not be safe? What might that do to the pain we feel? The experimental evidence suggests that it can increase it. So here I think it's really relevant to look at scans, particularly because oftentimes they've been interpreted in such a way that I think they have the ability to provide danger cues. So when we talk to people with osteoarthritis, many of them will say that they've heard things like this. You've got the knee of an 80-year-old, which, fab if they're 100, but if they're 50, that's quite a concerning thing to hear from a health professional, isn't it? Or, this is the worst x-ray I've ever seen, or even a saying, your joints, they wear out as you get older. Better get used to it. This will be here for the rest of your life. Or even hearing terms on your x-ray report like bone on bone or degeneration and wear and tear. All of these provide this, potential danger cue and this message that, your joints are vulnerable. It's probably just going to get worse. You better be careful how much you do. And the problem with this is that that's not what's supported by the evidence. So if we look into the evidence in this area, what we see is that x-rays and scans, they do not tell us much about the amount of pain that you feel right now, the amount of pain you'll likely feel in the future, and they certainly don't tell us about how much activity you can do. Now, this might feel hard and make people feel annoyed or mad or angry, and that's okay. But what I want to be clear about here is I am not saying that the danger message from the joint isn't important. It is really important. But what I am saying is that scans aren't good at capturing that. So remember all the changes that I was talking about before that happen in the nervous system that can change how much pain you feel. It's no wonder scans aren't able to capture that. They don't look at that. It's a little bit like saying, well, I looked at a picture of the family reunion and everyone was smiling. It must have gone perfectly. And clearly we know a picture of a family reunion is a snapshot. And there was some sort of argument over potato salad or meatballs, something that erupted hugely. So we don't want to put too much reliance on scans when they don't tell us necessarily what you're able to do. And in fact, many of the high level organizations, they recommend that we don't use scans to diagnose osteoarthritis for this exact reason. Because we can diagnose osteoarthritis just as well when we look at clinical symptoms, because ultimately that's what we have to use when we look at scans. So what I think is becoming interesting then is understanding that scans and x-rays don't really tell us much about that. But what they do tell us about are often findings that can be quite normal, actually, as we get older. So many of the reported findings that you'll see, if we look at people that are about your same age, but they have very little or no pain at all, they'll also have some of these scans or findings on the scan. So they're potentially a little bit more like seeing wrinkles on the inside. And we do see that often these findings, they were likely there before your knee pain started, and they will likely be there well after your knee pain has reduced. Because remember, there's lots of other things contributing to knee pain. And of course, they do tell us important information, you know, that your knee joint is this nice, strong, stable joint that's surrounded by muscles and ligaments that, you know, is suited absolutely perfectly for loading and thrives on movement. So when we look at these scans, probably a better way of framing this is that, you know, these scan changes, they're about what we might expect. We think of them a little bit like wrinkles. Critically, they do not determine what you're capable of. And part of this is that we are all bioplastic. And this is a term that means our systems can adapt and change right up until the very end, right up until our last breath. And that is a really actually important concept, is this idea that we're bioplastic. So just like the cuttlefish here who can shift and shape the colors that they have, we might not be able to do it this quickly, but our body tissues and our body systems have the ability to adapt and change. So when we lift weights, we get larger muscle size and improve our strength. When we practice, you know, a certain cognitive test, we often get quicker reaction times as we practice. When we do weight-bearing exercise, we can get thicker cartilage and increased bone density. And we also know that our pain and the immune system that I was talking about is bioplastic as well. It is changeable. And to me, this gives hope. It means things can improve. So we have now gone through another big chunk of information. Take a shoulder turn if you need, a big stretch, a blink, a neck twist, whatever you need to get that information solidified. But what I wanted to come across from that, the last bit, is that there are many contributors to osteoarthritis. And that's actually a really good thing, because it means that we have many treatment targets. And so what I would like to do is I want to explore now what this means in terms of your treatment. And when we look at the available literature, what we're starting to understand is that it's a little bit like key ingredients of making bread, where you need flour, you need water, you need yeast. Your steps to OA recovery also have 3 key ingredients. And those really are increasing knowledge, increasing activity, but also decreasing inflammation. Now, some of the increasing knowledge part, this is the stuff that I've talked through so far. These are the things like understanding why it's okay actually if your knee hurts a little bit as you move. But ultimately, it's really shifting the mindset from the old view of osteoarthritis, where, you know, it's a knee cartilage problem that is a mechanical wear and tear that's bone on bone caused, you know, by overuse, and the future is determined. There's not much you can do, probably will get worse and you'll eventually need surgery. And shifting that really to the new view that's supported by science, current science today. And that's really that OA is this mild whole body inflammatory process that can affect any joint. Often it can occur in the work that we do, we look at the knee, but that many factors contribute to osteoarthritis that include things that are going on in your knee, things going on in your gut, things going on in your thoughts, and the future, importantly, can be constructed. There are many things that you can do to help it. It can improve, and critically, it may not need surgery. And I think it's also understanding this, the evidence for why we really do think that exercise and activity is one of the best treatments for osteoarthritis and for pain. Because we know, of course, there's general benefits. It's increased confidence, it improves your mood, it's been shown to help with quality of life. But there's also really relevant benefits. When we do habitual exercise or do it daily, there's evidence that sustained exercise increases anti-inflammatory cytokines, so things that help reduce inflammation. Not only that, it improves the brakes of your pain system. So it can help increase inhibition, that thing coming from the brain to the spinal cord to decrease the sensitivity of the system. It improves cartilage health. So in people with OA, there's evidence to suggest that it improves the cartilage health. When we have continue doing exercise and we sustain it, it can help reduce body weight and improve through fat loss. And this can, if you remember that weird word of adipokines, that can then, with less fat, less adipokines, which also reduces the inflammatory response. And we're starting to have evidence to suggest that when we slowly increase your exercise levels over time, it decreases the overprotectiveness of the pain system, even in people who have severe osteoarthritis. When we add exercise and activity to education, it's also really helpful because activity improves your brain function, learning, and memory, which, if you've had chronic pain before, that can be a real challenge learning new things. So we're getting the best of both worlds. But the point of all of this, the point of doing these, is to induce bioplasticity in our system. Our systems need that little push. They need that little change to induce changes within them, to induce that bioplasticity. And this is particularly relevant when we look at that ability of slowly increasing exercise over time to reduce the overprotectiveness. If we go back to this figure that I showed you before, what we're suggesting and what science is finding that gradually increasing exercise can do is this. In people who have osteoarthritis, increasing exercise gradually over time can improve the tissue capacity. It can make things more resilient. And here I've had it go completely back to normal. It might not go completely back to normal in some people, but it might in others. But what's cool is that we're showing evidence that when you slowly increase activity over time, what you effectively do is you reduce the size of the safety buffer. And which means ultimately that you can do more activity. And despite doing more activity, you have less pain because you're not pushing into the safety buffer. But, and so we've done a study that has shown that this has been quite useful. So people, despite the fact they're walking more, they actually have less pain. So what we have also, an important aspect of this is knowing how much to do, isn't it? Because that's not clear. That's not something that we definitely know. And what we would recommend is working with a health professional to find what we're going to call your sweet zone, or your Cinderella zone, your Goldilocks zone. The part that's not too much, it's not too little, it's just right. And the key with this is we don't want you going out tomorrow and running a marathon. That probably will be too much. And we don't want you to, just walk to the kitchen. That might not be enough. And so it's working with a health professional to find the amount of activity that just pushes that edge of your safety buffer. So it's a little bit of discomfort, but it's maximizing that bioplasticity and that ability of your system to change and slowly increasing that over time. What they can also do is when you're doing different activities, looking to reduce those danger in me's and add or enhance safety in me's so that the experience itself is less likely to induce higher levels of pain. So together, your health professional can play a really important role in helping you navigate these increases in activity. And the last aspect that I refer to is decreasing inflammation. And there's good evidence that things like a Mediterranean diet where it's olive oil, it's fresh green veggies, dark chocolate, different fatty acids through fish, they're helpful in reducing inflammation. Critically, I'm not a dietitian or nutritionist, so I would suggest working with one that is advanced in that area. But we also know that, as I mentioned before, that activity levels can decrease inflammation through various different means. And interestingly, if you remember, I spoke about the microbiome, our gut bacteria that can influence inflammation. when you have daily good diet choices and daily physical activity, that can help shift some of the long-term effects of microbiome and actually shift it more, not permanently because it's always changing, but in a larger manner and have larger effects on inflammation. So daily things are really important. And last but not least, we're starting to understand that actually our thoughts and our beliefs, they can have influences on inflammation. So there's evidence to suggest that when we feel optimistic and positive about things, that can induce lower levels of inflammation. So isn't it incredible how our body systems are interrelated? So I would suggest that the available evidence paints a more complex picture, and that advice to move actually makes sense when one understands that osteoarthritis is this dynamic, low-level inflammatory process that involves nervous system, the immune system, the gut, the diet, adiposity, the mind, past experience, the environments, the joints, ultimately the person, and all of which is marvelously bioplastic. So in summary today, I hope that I have convinced you that osteoarthritis pain is complex. It's not just about the joint. It involves this low-level inflammatory condition, but with also many other contributors to pain. And this means, importantly, there are many targets for treatment. Critically, like this chameleon here and like the cuttlefish, we are bioplastic. And exercise and education are some of the best ways to retrain an overprotective pain system and encourage cartilage health and reduced inflammation. We need to change our words, don't we? Wear and tear? Nah, throw it out. The new terms are wear and repair. And last are 3 key ingredients to recovery: increasing knowledge, increasing activity, and reducing inflammation. And working with your health professional to set up these plans for you. Thank you so much for your attention, your time. I'd like to thank some of the people that I work with in my lab, some of the funding sources where I have kindly received support, and then I'll pass it over.
Thank you very much, Tasha. That was excellent. Really interesting talk and loads of thinking points for people and talking points for people, which we'll come to. But first, I want to introduce our panelists in advance of the question and answer session. I'm going to introduce each of them and then allow them each to explain a little bit about their backgrounds. So first of all, I'll come to you, Louise Truhan.
Sorry, just trying to unmute. Can you hear me?
We can.
You can?
Yeah.
Yeah. Hi, so I'm Louise Truhan, and I live with fibromyalgia and osteoarthritis. I'm a Vice Chair of the Patient Voice Committee of the British Pain Society and many other hats that I wear. I'm really pleased to be here today.
Thanks very much, Louise. Next up, we have Ian Taverner. Hi Ian, can you hear me?
Yeah.
Just get the technology in order.
Come on. Right,
There you
can you
are.
hear me now?
We can.
Hi, yes, I'm Ian Taverner. I live with arthritis, fibromyalgia, anxiety and depression. I had to give up work and was housebound for many years due to ill health. I turned that around in 2019 at the NHS Centre for Pain Services in Bath, and I've just published a cookbook called Cookfulness, which is to help people suffering with pain, physical and mental, to get in the kitchen and get a bit of the cooking power that's really helped me, and I'm delighted and honoured to be here. Thank you.
Thanks very much, Ian. Kat next, joining us from the USA, Kat Glow.
Yes, so hello everyone, my name is Kat. I use she, her pronouns, and as you've already heard, I'm American, joining you from the Appalachian foothills of Southeast Ohio. I was diagnosed with juvenile arthritis back in the 80s, and I remember it taking ages for my family and physicians to take my growing pain seriously. And then I just remember the giant pink anti-inflammatories that I was prescribed. This was likely one of the earlier experiences that shaped my understanding of pain. But the messages that I received were first that I couldn't be believed, and then that I would likely experience pain throughout my life because my body was, messed up, prematurely old, like my grandparents. As an adult, I've collected other diagnoses and have been learning to live well with persistent neuropathic pain. Getting a better understanding of the biopsychosocial nature of pain and the many things we can do to affect that experience have been life-changing, truly flipped my understanding, if I can borrow a phrase. But I've never really connected that growing knowledge with something that I've seen as biomedical, as arthritis. And I'm really grateful to Tosh today for having flipped that understanding once again.
Thanks very much, Kat. Thank you. And next up, we have Dr. Ben Dean, who is an orthopaedic surgeon. Ben, do you want to introduce yourself a little bit further?
Yeah, hi, I'm Ben. I'm a hand surgeon from Oxford, and I've kind of got research interest in pain. I did a fair bit of research in my PhD on shoulder pain. I'm kind of now got research interests relating to hand arthritis, wrist pain, and quite interested in kind of patient experience, clinician experience relating to quality of life, general pain impact in common conditions. So that's me. Thanks.
Thanks very much, Ben.
Great talk, Tasha, by the way.
Thanks, Ben. And Dr. Asim Suleiman, you're next up at GP.
Hi, can you hear me all right?
I can.
Excellent, thank you. It's lovely to be here. My name's Dr. Suleiman. I'm a general practitioner by background, but I have an interest in chronic pain. I also work as an occupational health physician, and my interest really, more so recently, has been around becoming more trauma focused in my pain management, as well as looking at pain management in disadvantaged communities.
Thanks very much, Asim. That's brilliant. And so, as you have been throughout the presentation, please do get your questions into the chat box. There is a thumbs up function, so you can highlight ones that you particularly like, and we won't get a chance to answer all of them, but we can head for the most popular ones. First of all, Tasha, again, just thanks very much for that presentation. I want to draw attention to one comment, which is thank you for offering hope, which is, I'm sure, one of your goals in doing this sort of presentation.
Thank you so much. Yeah, and I do think that that's something that certainly when we've spoken with people that have osteoarthritis, it's sometimes been something that's really been lacking. So I feel I'm pleased that that's come across, and definitely I think that we can certainly say that that hope is supported by the science.
Oh, brilliant. Some huge questions. So one of the ones I want to come to is, it ties in with a question that I've had. Now, a lot of people have heard this bone-on-bone diagnosis. Is it actually a thing? Can we get actual bone-on-bone? We hear it so much. I'll come to you, Tasha, for that.
Sure. I'd be very interested actually in hearing what the others have to think with this. I suppose from the work that we've looked into, when we see, various different x-rays or things like that, inevitably, well, you might but might look like it's like smashing in. For many times, you will still have various things in the joint, such as things like lubricant. And lubricant is one of the most slippery substances in the whole world. We've never been able to recreate it with any of our man-made technology. And so even if those things look close together, there are still substances and things in there that mean that they can move. And I mean, I've not seen instances where we've not been able to have improvements with people, even though they've had, dire looking maybe x-rays. Or we even had one fellow who come in who, it was interesting, he came in to see me for his left knee and actually had x-rays of both knees. And I was absolutely certain it was going to be his right knee that was sore based on how bad that x-ray looked. And it wasn't at all. It was the knee that was less sore. So I think, again, regardless of sort of what we see on those things, it doesn't necessarily relate to the pain that people are presenting with and experiencing. Thanks very much.
Ben, I'll come to you with that same question. You are an orthopaedic surgeon. You have literally seen inside people. Have you got any thoughts on bone-on-bone as a diagnosis?
I think Tasha's quite right. it's not really of importance for most patients. Are often afraid of it, and it sometimes provokes a bit of anxiety and fear in patients. I think it's really important to communicate that it doesn't really matter in terms of how you're going to treat it. You still approach it with the kind of your standard treatments. You're not going to rush into surgery just because someone's got bone-on-bone arthritis. A large proportion of people with bone-on-bone arthritis have no symptoms and never go and see a doctor. It's very important to get that across, and we've been doing some research looking at it, and the therapists keep telling us basically that it doesn't matter. We don't treat the patients any differently. The pain doesn't align with what the changes are. From a surgeon's perspective, the more you can, surgery is always a bit of a gamble, I think, in anyone. You can't reliably predict that everyone's going to do well, and Tasha's quite right to point out when you look at large numbers of people having surgery, the outcomes can be favourable, but I know on average actually a fair few people do have persistent symptoms, particularly with knee arthritis. The key thing is that as a surgeon you can stack things in your favour by, we know that there's good evidence that the more advanced the structural changes, the outcomes are better with surgery, which makes sense. If you've got mild structural changes, in my opinion, surgery is a huge gamble and is best avoided for most arthritis. If people have advanced end-stage OA, then surgery is something that can be considered potentially. Doesn't mean you have to do it, but it's definitely something that can be considered, and the odds are generally better. There's lots of work on knee OA, particularly showing that advanced bone-on-bone OA, the results are much better with surgery than people with milder OA, which makes complete sense. If you're operating for pain by improving structure, then if the structural change isn't bad, then you're not unlikely to make a great deal of difference to the patient.
Oh, brilliant. Thank you very much. Several questions on the theme of weight. I think it was a huge topic and something that we all think we understand. If you're heavier, you're going to put more load through your joints. As you say, Tasha, that's probably not what the evidence is actually suggested. I'm going to go through a few questions about weight, and let's we'll head to the most appropriate people. So first of all, Tasha, can I just pick your brains about the research that you mentioned about the correlation between obesity and OA, regardless of where that OA is, whether that be the hands, the hips, the non-weight bearing or weight bearing joints. Somebody's asking, is there an established cause for that, or is it merely just they're observing a correlation and we go, oh, that's interesting, or does there seem to be a cause there?
Yeah, it's a really good question. So some of the research that I presented there was mainly looking at associations. They were longitudinal. So we're looking at a predictive type model where you're trying to control for a lot of other different things that might also be influencing the outcome that you have. But we do always have to be a little bit careful. So it's stronger than cross-sectional data where we're just looking at one point in time where that's very hard to know if anything might be causal, but it is longitudinal, so it's a little bit better. But I guess there's some work going into whether some of these, like the development itself of osteoarthritis, and whether so instead of kind of trying to look later down the line, is this causal of progression? It's saying actually when we have some of these factors, such as let's say higher central stores of fat combined with some of these other factors, does that make actually the development of painful osteoarthritis more likely? And does that make some of the structural changes perhaps larger that we see? And there is some evidence to suggest that those factors can play an important role. So things like obesity within that development of osteoarthritis. And to me, that provides a little bit of a stronger bit of evidence to support this idea that it actually does play that important role.
Thanks very much. Another question related along the weight bearing side of things was, if loading helps, why is it that some clinicians limit loading? Somebody else said, why am I being told to avoid the stairs to avoid, flaring up my knee pain? I think possibly useful to come to Asim on this as a clinician who talks to people with arthritis yourselves. Is this a misunderstanding amongst healthcare professionals as well?
Thank you. Thanks, Flick. Yeah, I think perhaps there is a little bit of, well, probably quite a lot of education needed from a healthcare professional point of view, really. I think traditionally in undergraduate, postgraduate education, we were, I mean, I'm just harping back to the earlier question from Tasha about bone-on-bone pathology. You know, we've been taught as we examine the joints, we hear crepitus, so that means it's bone on bone. So from a point of view of weight bearing and how that impacts on joints, I think there's been mixed messages over the years, to be honest, but I think the education is now becoming quite clear, and the neuroscience is becoming quite clear, and that physical activity, I try not to call it exercise anymore, I call it physical activity, is going to be absolutely the way forward. And it has to be, I guess, catered for the people who are living with pain, and doing what they're able to, as mentioned by Tasha.
Thanks very much. That's brilliant. I'd like to come to Louise. I know you have been on a weight loss journey in the past, and I wondered if you wouldn't mind commenting on that.
Yeah, absolutely. I mean, I was on high dose opioids for over 13 years for my osteoarthritis and fibromyalgia pain, which saw me rise to 25 stone in weight before I went into hospital to come off, despite my efforts to lose any weight. And of course, the bigger I got, the less I could do. And it was quite quickly after coming off the opioids, walking was my thing to cope. So the more I was active, and I hate the word exercise too, just conjures up the wrong image of people having to go to a gym or jogging down the street, and when you've been living with pain, that's just not possible. That puts people off. So yeah, movement, and for me it was walking, and as the more active I got, the more weight I lost. I've got to a total of 8.5 stone lost now, still got a way to go, but I've noticed that as the weight has come off, the pain in my knees and feet from osteoarthritis has improved. So I can totally relate to everything Tasha was saying in her presentation, and also the fact that the more I've put load through it, the more it has improved the strength that I feel is in that joint as well. So yeah, I can vouch for that. It works. It's true.
Brilliant. Thanks very much, Louise. Thank you. I was drawn to one of the comments about being overweight and living with arthritis in the comments, and someone had comments about the narrative around obesity. They said, you know, they're living with OA. They're told by their GP and their consultant that it's your fault, you're obese, you need a knee replacement, but you're too overweight for us to give you one. So they're discharged with pain relief. They say they're feeling quite depressed about this and in pain, and it inevitably leads to that cycle. Is that something that, I'll come to you again, Louise, on that, having been through weight loss yourself, is that something you identify with?
Yeah, absolutely. And I think you get stuck in a cycle. I know for myself, it turns out afterwards, after I came off opioids, I learned that the cycle I was in, I was never going to lose any weight. It didn't matter how healthily I was eating. I didn't have all the components necessary to lose weight. And coming off the opioids was a big start for me. And I mean, not everybody needs to come off their meds. I was on a dangerously high dose, but you need to have all those factors in place. And I felt awfully stigmatized every time I went to an appointment. I felt that everyone was looking at me because I was so fat, and it was my own fault I was in so much pain. So I totally relate to that. And I think it's just taking those first steps to understand the problem. And I really liked what Tasha was saying about education. If you educate yourself as well on it all, that helps enormously. But yeah, I totally get that.
No, thank you very much for sharing that. I will come to Ian as well. Ian, we have talked in the week about your arthritis journey. Do you want to share a little bit more in terms of this issue about weight?
Yeah, it's really important, because I know I am overweight, but I've lost weight since I started getting active, and being active and chronic pain seem counterproductive or counterintuitive. When you're suffering, the last thing you want to do is move. and physically and mentally you go very inward, and that just seems to be the way you go, and there's nothing to say actually that's wrong. You need to be working on your mental health, your physical health. Both of them will help you to start to move again. And it was only when I started to, I mean, I had both my hips replaced at 46 as part of the sort of program I was on, and it's helped. But I think looking back now, if I'd go back to that point, I would have looked at what other things differently I can do, particularly what's being said here about exercise, movement, whatever you want to call it. That for me has been probably one of the best things I've done, is started to move, because you're not scared of hurting yourself anymore. And I think it's only when you understand that you're not going to make yourself worse, that you can get over that, which is, what Louise was saying as well. No, absolutely. I think it's important to understand. I guess it's not as straightforward as, oh, we'll lose the weight and then you're going to end up pain free. It's I think there's a whole lot of work that needs to happen as well from healthcare professionals to advise on that. Tasha, I'll bring you in on that as well. Obviously, you've presented the research to us there. Have you anything to share on top of that?
Yeah, I think the challenge with, I hear you completely, Louise and Ian, that the challenge with that is certainly with stigma and things behind that. And I guess from a personal perspective, I don't like really, or I don't know how useful sometimes the focus is solely on losing weight as a goal. That is, of course, an important thing, but I guess for me, it's actually really about decreasing inflammation. So by adding all of these other different things in, of which, things like activity and things like better eating might also help with losing weight, the goal really is decreasing inflammation, and losing weight is one of the things that's helping. So I don't know, I guess in some ways, I'm not sure if that would be a helpful thing, but somehow in my mind, if I'm thinking, I would much prefer a goal of increasing my overall health and reducing inflammation than going down the route of feeling like the only way that I feel like I might ever get better is that I have to lose weight, because it can take time and it's hard. It can be lose motivation, but that comes probably from my personal thoughts about what we might do to frame goals in that area.
Brilliant, thank you very much. There's a question as well, other questions from people who perhaps don't have issues with weight, but want to know kind of what they can do besides that. So, for instance, there was somebody who said, well, I exercise 5 to 6 times a week, I'm slim, what else can I do? And I guess that speaks to the bigger picture. It's not just a case of, well, lose weight, exercise. As you talked about, Tasha, there's a lot more to pain than two things. There's the threats and the safety aspects as well. I'd like to come to, let's bring Kat in, if that's okay, in terms of what else there is aside from being active that helps with pain management.
Yeah, absolutely. And that, honestly, has been kind of one of my mind-blowing takeaways from Tasha's presentation today, is I've always seen osteoarthritis as just purely biomedical, bone on bone, these messages that we get, societal messages forever. But not just reducing inflammatory processes, but I know that other kind of biopsychosocial aspects that I've used, such as meditation, relaxation, pacing. I know for me, I had to be in kind of a fairly desperate place with a somewhat rare diagnosis to accept that was a path that could help me as a patient, as someone who is living with pain. And I'm curious, with Tasha or Ben or Asim, how do you get a patient to the point that they're receptive to those messages? I've kind of self-selected. I'm here because I'm interested in pain. I have, my own personal experiences, but not everyone is ready to hear those messages, or in a place where they're received in a way that's helpful. So what advice do you have for clinicians working with patients like that?
Let's go to Asim first on that one.
Sorry, just unmuting. Oh, that's fine. Okay, so yeah, what I tend to do is, I mean, I could talk at length, obviously, about how and all the different kind of multifaceted approaches to pain management that are available. However, I think one of the key things I try and do is to use motivational interviewing techniques to try and help try and help those people who are struggling with pain, and that does take time. It takes multiple visits, perhaps, and it is clearly, as I'm sure some of you know about motivational interviewing, it's about improving, giving them the skills, but also the confidence to make those small changes, and small steps is what helps, in my experience, those people who are really quite struggling at times. I've also found that, and I'm finding more and more so, that with the recent NICE guidelines which came out, saying essentially that medication isn't particularly effective for chronic pain in the long term, we're going to have to start looking at different ways of helping people who manage their pain. And I think personally one of the ways forward is peer-to-peer learning, really, community groups, and patients. I use the word patients hesitantly. I'd say people who are living with pain learning from each other, and building the skills in between them in the peer groups, giving themselves each other confidence, I think has to be the way forward.
Wow, thank you very much. Ian, we have talked previously about your, and as you mentioned, your pain management program experience, which is just that, isn't it? It's a group effort. I also wanted to kind of open up that initial question about the bigger picture of pain. Would you be happy to share more on that?
Yes, absolutely. I think the big issue around safety, and also how do you get someone to see what it is that they want to do. Someone asked me the question, what do you really want? And that blew my mind because I didn't really know what the answer was. But it was only really when someone asked me that and I started to think, well, actually, I want to get back to being a person within my family again. And then how do I build that to actually make these things happen? And yes, there are certain parts of it that are down to medication, etc., etc. But for me, the biggest thing that came through was I want to get back doing some cooking again. Now, you think, well, is cooking really a therapy? Well, for me, it is, because it's that huge safety area. It's that part that boosts my self-esteem and my pride. And since I've been cooking and since I've been talking about this book, my pain levels are not as bad as they've been. I still get pain and I still get flares, but because I'm doing things constantly that I'm enjoying, and enjoyment was something that I'd lost for many years, but once I've got that enjoyment back in something, it starts to breed other things. So now I'm happier, so I'm moving more, so I'm doing more, and it sort of breeds more and more on that whole sort of roller coaster, I guess.
That makes sense. Would you say it's as I often say when I'm listening to people who live with pain, it's often the fun stuff that disappears first, and in your case, Ian, it sounds like being a dad, being involved in the family stuff, and it's all very well for us to say, oh, well, try losing weight and try doing this exercise, and if that's not a particularly fun thing to do, maybe it doesn't have the best impact on the pain. Would you agree? Totally agree,
and what Tasha was just saying, that weight loss is almost a result, not what you should be going for. I spent years thinking that the best thing to do was for me to sort of isolate and not have my family worrying about what I was going to do or not do. So we almost ended up with two lives, and that we thought was the right thing, but actually it was totally the wrong thing, because my mental health was suffering as a result as well, as was everybody else's. So I think once you realize that there are ways that you can take steps forward, it's huge for your physical, your pain levels, by actually doing more. And also what happens then is that by me doing more, I started to go to school events. I've missed 10 years worth of school events, of Christmases, of everything. As soon as I started to go to those things, I was feeling better, and seeing my children happier made me happier. And it sort of cycles that way. But unfortunately, if you're going the other way, which I was for many years, everyone spirals the wrong way.
Yeah, I guess it makes sense, going back to what Tasha was saying, if we're very protective of ourselves, no wonder our whole nervous system becomes very protective as well. Let's talk about surgery. There's a lot of questions about that, and as you'd expect when we're talking about arthritis. There was a question that how do you know when it's time to have surgery? Based on what we now know about arthritis, where sometimes the pain can be more led by that perception of threat within the body, how do we know when surgery, which very much targets the anatomy, is the answer? Ben, I'll come to you as a surgeon on that one.
Can you just repeat that again? Sorry.
Yeah, certainly. So there was a question about how do we know when it's time to have surgery versus should I just spend some more time making other lifestyle changes or trying to adapt the joints?
Oh yeah, that's a great question. I'm kind of really interested in that at the moment. We don't know is the bottom line in my area in hand arthritis. Basically use the current model of care is kind of hierarchical, and we start with the simple, less risky things first and kind of build up to the more invasive interventional things over time if the other things don't work. And in base of thumb arthritis, which is the most common form of hand arthritis requiring surgery in the UK, we end up, patients will have treatment for months and months. They'll have 2 or 3 steroid injections at least most of the time before they end up having surgery. We have no idea though which patients should have surgery when. Should it be earlier? For some, maybe it should be when they have a very advanced structural change and they have a kind of stiff thumb in the palm. There's a general thought that they do very badly if you leave it too long because the thumb just gets so stiff and stuck, it doesn't really work very well ever again. But then do we jump into surgery too early sometimes as well? Probably do, but it's so hard. And I think the most important thing is the patient's expectations, belief, and what they think about surgery, because, you know, if we don't have the evidence to prove when surgery is most effective, we have to explain that honestly to the patient, say there's uncertainty here, explain what surgery can do, what it can't do, what the outcomes are like, give them the information about all the treatments and try and let them make that decision. The difficulty is with shared decision making, if the information is poor and the evidence is very uncertain, then it leaves the patient in a very tricky position. And they often want us to make the decision, which we obviously try and avoid because it's a very hard decision. And I don't have the answer.
No, it's a difficult question. Tasha, I'll bring you on this one as well, and then after that, let's come to Ian about your experience having had surgery.
Yeah, so probably speaking more than from weight-bearing joints, or particularly at the knee, I think there's consensus, certainly within Australia, and I think probably with most of the other guidelines, that really it's best, almost no matter what your situation, to undertake a proper full course of trying to increase activity levels, because we don't really have very many good ideas or strong predictors of whether or not people will respond, because people who actually have very severe so-called structural changes that we see on X-ray or MRI still actually can respond quite well to activity levels. And so, and also these, educational interventions that helps them, I think, better understand what might be going on with their symptoms. So I think that's probably a really important thing, because we actually see that, quite a few people in Australia anyway, they go direct to a surgeon and don't undergo that level of trying out activity. And, if the worst case scenario really is that you go into surgery a little bit fitter than you were before. And we actually know that going in fitter, you tend to have better outcomes from surgery for lower limb surgeries like knee, total joint replacements. So I think probably from that sense, I think it's worth a go. Having said that, there's some people that may not have had a chance to do that and go into surgery, and oftentimes they can still have okay outcomes, and that's wonderful. It might just be making a concerted effort to try to increase activity levels after surgery, because oftentimes we see that even though pain might be less for some people after surgery, it doesn't necessarily mean they're moving more. And there's so many benefits to moving that be even beyond, osteoarthritis, that I think that is a really important goal for someone after surgery.
Oh, thanks very much, brilliant. Ian, when did you know that it was time to have surgery?
Well, I'd been having problems with the hips for quite a while, and particularly at night, it was very, very painful. So I'd been seeing a specialist for quite a while. We tried steroid injections into the hips, didn't really have any effect. So we sort of went straight to let's replace them. And to be fair, I wanted them replaced because in my mind, that was the holy grail. That was going to be the way that I was going to be fixed, not knowing that actually this was just a part of everything. It wasn't, it wasn't going to fix me. It had helped, but it also, at the time when I was struggling to come to terms with all of the pain, being in and out of hospital a lot fueled more of my inability to cope. And see, you're surrounded by people who are all suffering, and it's not a great environment to give you that boost of well-being. I also had, I was in and due to go down to theatre, and then was told, sorry, we're going to have to, you have to go home. Now, when you're suffering and struggling, that's a really hard thing to take. You put a brave face on it, but inside you are churning up inside. When I had the surgery, it was done incredibly well, and it's helped me because strangely, it forced me to move. Because I knew I needed to do the recovery program to help me go, and then I realized that I could do things. So it had pros and cons for me, but so I'm glad I had it done. But if I had my time again, I think I'd do it differently.
No, thank you very much. There'll be a lot of people who are listening who, because of COVID, have had their surgeries delayed, I'm sure, as well. So certainly a useful message to hear. A couple of questions about steroid injections as well, which is often an alternative treatment offered to surgery. I'll come to Louise second on this, who's had some experience receiving them herself. But I also want to bring in Dr. Azam as well, who, as a GP, when would you be recommending steroid injections for joints?
Thank you. Thanks, Felicity. So now I think most CCGs will probably have some sort of musculoskeletal pathway in place now, probably more so post-COVID as well. And it was interesting when COVID hit March last year, slightly before, and we stopped steroid injections. We didn't get much pushback from patients. And what's happened since then, obviously, as we've slowly released out of lockdown, and I'm not sure what it's been like in Australia and other places, that demand has started to peak once again. And patients are wanting steroid injections for shoulders and hips, etc. Now, the CCG, the place where I work, essentially are saying follow the pathway. And if you get down far enough along the pathway, you may be offered a steroid injection. But in my feeling is there's definitely a move away, and I think the evidence does show this, that long term they don't really improve outcomes, and if anything, they're more used for short-term pain relief. And it'd be interesting to know what Dr. Dean or Tasha would say about that.
I will bring Ben in on this before I come to Louise. Ben, have you any thoughts on steroids?
Yeah, I think the pandemic's had an influence, but I think there's probably kind of changes that were underway before then. And I think steroids, it's been a bit of extremism, both ends of the spectrum. Some people never want to use them. Some people want to dish them out like Smarties. And I think the truth's somewhere in between. As Ash said, Asim says, I think they're an effective short-term pain relieving measure, and actually the side effect profile is pretty favourable. They're fairly cheap, fairly easy to deliver on the whole. And I think for people that have tried other things, or someone who's in a really, really bad situation with pain, they're quite an effective short-term, 2-3 months-ish. On the whole, it seems to be effective for, versus placebo. It's not in all joints, but that seems to be roughly across the board. So it can be quite, I think the context is really important to explain to the patient. You don't want to get, a lot of clinicians are quite right, you don't want to get trapped into the cycle of giving injection after injection after injection. I think the harm of one injection is probably very, very small in terms of, potentially longer term damage to the joint. I think one injection is very, very safe. Lots of injections, your risk's going to go up and up and up. we don't really know, but we suspect if you keep giving repeated injections, you're probably going to get some bigger and bigger harms and worse side effects. So I think it's really important to explain to the patient, yep, it's good to have in the locker. If your pain's not manageable at the moment, let's keep it in the locker. If it's really bad at the moment, it's a good short-term fix, but we don't want to get in the cycle of these injections. I tend to say to patients, if your pain is better at 6 months after your injection, it's likely that's probably not the injection, that's probably your body coping and generally just settling down. So then you can avoid getting stuck in that cycle of someone wanting to come back for injection after injection after injection. But yeah, don't throw the baby out the bath water. Steroids, I think, are useful, but being cautious is sensible.
Ultimately, do they just work as an anti-inflammatory? Is that their mechanism?
Well, we know that they have multiple effects, and like all treatments, the biggest part of treatment effect is probably contextual. So how you deliver it, the communication, all the rest of the package. Even an effective operation like joint replacement, still a big chunk of that effect is just contextual and placebo. So yeah, part of it's contextual, part of it's placebo, part of it's anti-inflammatory, but that's not only just locally anti-inflammatory, it's going to have systemic effects as well. So it's incredibly complicated. It will also have effects on your peripheral receptors, mood, cortisol, etc. No one really understands it that well, and all the different steroids we use are actually slightly different and have different effects, different durations, have different effects on all these different parts of the body system. So yeah, it's kind of interesting.
Yeah, complexities everywhere when it comes to pain. Louise, just before we wrap up, I'll come to you about your experiences with injections as well.
I think it's really interesting one, because while I was at my worst and heaviest, I had them as regularly as you're allowed to have them in my feet, and they were an enormous help. And actually, when I came off the opioids 4 years ago, I've only had one episode, one lot of injections in the feet, and the surgeon was happy to do it because I walk for my pain relief and therapy now, and he could see that I was losing weight, I was improving, and so he was happy to do them again. I hadn't had them for such a long time, and then lockdown hit and we were limited to how much walking we could do, and I'm actually due to have some more injections next week, but that is the first. So it's like the biggest gap since coming off the opioids. I didn't have them anymore, and now after a year of lockdown and limited availability of being able to go out and walk the coast paths, etc., and my pain increased, and so yeah, I'm having some more. But I think I agree with everything that's been said there. It's good in the short term, but we need to realise we have to address the bigger picture.
Thanks very much, Louise. And thanks to everyone who's joined us. That brings us to 6:30. It always flies by. Thanks for joining everyone in the audience. Thanks to Tasha and all of the panel. Huge thanks to Pain Revolution Australia, who've always been the inspiration for this project, for Flippin' Pain. Do check out our resources, so the ones that you'll see on the slide here, including Pain Revolution and their resources at Tame the Beast, the Pain Toolkit, our website flippinpain.co.uk, and Live Well with Pain. If you enjoyed this, if you've got any feedback, please do drop us a line, info@flippinpain.co.uk, and follow us on social media @flippinpain across the board. Thanks very much, as I say, again, for joining us, and we'll leave you there. Thank you. Goodbye.